Thank you, Professor. It's an absolute pleasure. Thanks, PK and Dirk, as well as Professor Biramino for the very kind invitation again. So Supera is all you need. It's really in the context of the calcific questions that we're having here. So when it comes to the shortcomings of SA stents, you've already seen a ton of examples that stents, particularly the nitinol laser cut stents, have some shortcomings, not just restenosis and stent fracture in the old days, but in the newer generation, they still have less radial force to resist the inherent resistance of expansion by way of calcific disease. And Fabrizio has already shown you some fairly good and cogent arguments as to why it becomes important. Well, the difference with the Supera is that Supera is a uniquely different nitinol design stent, which actually, when deployed appropriately, actually achieves a nominal circular form, and that actually resists the calcium to a much greater degree, in fact 5 times a greater degree than any other stent on the current market. It actually has a much higher radial outward force in its interwoven design compared with the nitinol laser cut design. But in doing so, it actually, unlike a laser cut nitinol stent, is actually able to separate both conformability with the radial strength. So the radial strength, if you made a nitinol stent today, radial force high, you lose all the conformability. But now with the Supera interwoven design, you maintain conformability as well as the radial strength. So Supera is about 4 times that, and its crush comparison is about 4 times the difference to 5 times the difference of any of the nitinol segments. But the real difference is that when you get nitinol stents, you start to bend them and contort them. You get these fish scalings that you see here. But nitinol in Supera, which are basically single interwoven wires of nitinol, maintain the conformability and do not fish scale. So they're conformable, biomimetic to the artery to a much greater degree. One of the trials, the pivotal trial in the United States that myself and Ken Rosenfield helped lead, really looked at this. This was based on the Viva OPG. It's a registry of the design, and our patient population had a fairly high number of diabetics and renal insufficient patients, so they did have some calcific disease. Calcium was deemed about 73% in the scaling score between moderate and severe, with occlusions occurring in about 1/4 of the patients. But our primary patency, which we'll get back to, but our TLR rate, which is our 3-year endpoint, showed that our TLR endpoint was 82%. So you lost 18% at 36 months, and the delta from year 1 to year 2 was only 7%. And so that actually is the best in class in the overall TLR rate. When you looked at severe calcification, the freedom from TLR went from 94 to 87% at year 3. It's a remarkable endpoint in that severe calcific patient population. But when you look at the primary patency, and this is a core lab-driven endpoint, this stent, because it's interwoven, is uniquely designed in how it's deployed. And so you have to vessel prep the area very aggressively. You have to go 1-to-1, if not greater, to the reference diameter. And the way that this is sold in the United States is based on its OD, so you actually have a 0.5 millimeter size bigger. So they come in 4.5 with an internal diameter that would be 4, up to 6.5 with an internal diameter of 6. So you want to pre-dilate to a higher degree, or 1.1, a 6.5 or a 7, to deploy a 6.5 balloon, or stent. Now if you do that, and you do it very well, in other words, you nominally deploy the thing so that it actually comes out within 20% of its nominal length, you can see the primary patency is remarkably good. Even if you compress it in those heavily calcified areas, which you can do, you can actually stack the stent through calcific areas, you actually get a very good primary patency at 1 year. However, if you do not deploy this stent very well and you elongate it, over 40% in some cases, that stent now works just like an old nitinol stent, and so your benefit here is greatly lost. And it's shown in the core lab adjudication at 77% at year 1, all the way out to 42% at 36 months. So Supera stent has been studied in over 1,300 patients, real-world patients, 86% primary patency in the SFA, and I think Dirk's group has really been the primary leader here. You can see that if you look at just the Viva endpoint, which is a 14-month endpoint, the Viva OPG, the Superb trial really stands out at 79% compared, and you can't crosstalk these, but in the scientific landscape, it compares very, very favorably to other trials which have gone before it in simple nitinol laser cut designs. In the Supera trial, we were consistent among all lesion lengths, both short, medium, and long. Again, where we live and breathe is not a pivotal trial of 8 centimeters, but rather that 20 to 30 centimeter length. And so the shortest lengths, all the way up to the 15 to 20 centimeter length, the Supera stent really does perform very well, both in the short term and in the long term. It's an excellent freedom from TLR through the SUPERB trial from year 1 to year 3 compared with the other trials and, as to an outcome. So in summary, if you really want to look at a stent, if you really want to have one stent on your shelf, the Supera really has performed as a best in class for the self-expanding stents at 1 year, with a Kaplan-Meier estimate of 86% on the 12-month window, 79% on the 14-month window. It essentially has 0 fracture rates. It's over 40 million flexes in the lab do not fracture this stent. Again, there are wires that are interwoven, not stents which are cut, laser cut. There is no drug and there's no covering needed to get this to principal outcome at 3 years. And the TLR rate of 82%, again, is the best in class over 3 years in that decline. The best outcomes depend on optimal deployment of this stent, and it has to be pre-dilated and vessel prepped appropriately to get an outcome which is appropriate for the stent that you would wish for your patients. But if you only had one stent that you could put on your shelf, one stent that you could have, like being on a desert island, what was the one thing you could have besides something to drink, it would have to be this stent in your shelf in your cath lab. Thank you for your attention.